It's my great pleasure to be part of this panel, and I'm really excited to get to present this study, which I believe from all the presentations that we've had from the other team members from the fetal medicine unit in Zimbabwe from yesterday, I'm sure we've seen a lot of the work that's being done in the unit, and that's a lot of effort and energy has really been put into trying to help our babies to fare better, basically. And so really a lot of the background work has been done for me in terms of the justification for my study, which was titled.
Sorry, Dr. Mumvuma, do you want to go on slide show? If you just go to from current slide there, then you can, so that is beamed up in slide show. Thank you.
Oh, sorry.
Yeah, it's good now.
Okay, good. Yes, so the title of the study was Early Neonatal Outcomes of Growth-Restricted Babies Delivered Before 34 Weeks at Salim Gabe Hospital, as indicated by abnormal Dopplers. Just some background information. Salim Gabe Hospital is one of the hospitals where the fetal medicine unit has a unit. These are tertiary, it's a tertiary hospital. So it's a referral center for high-risk pregnancies in the country, one of the main referral centers. And well, this one was singled out as opposed to the other one. Yesterday, I think we heard that we've got 2 units in at central hospitals within the country, because at this particular center, there is also a neonatal unit, which is large and it's got a large database, electronic database, as this was a retrospective study. So that was felt to be significant in order to be able to get some data. And we've heard about the early onset.
Sorry, your slides are not moving, Dr. Mumvuma. Do you want to?
Sorry. Okay.
Okay.
Sorry. Yes. So we've heard about early onset fetal growth restriction as well as late onset, but my study focused on those below 34 weeks or up to 34 weeks, mainly because other studies have shown the risk of prematurity to become less significant from 34 weeks. So since the opening of the fetal medicine unit, the diagnosis as well as surveillance of growth-restricted babies have been going on. As we heard even this morning, that this is the most common problem condition that is diagnosed in all the women being scanned there. And this has obviously got a background of various maternal conditions and others who have been referred simply for having been discovered to have small babies. And so we've had the protocols that are in existence that follow up these babies and the pregnancies. And then delivery is usually then determined and advised when the risks of continuing the pregnancy in that hostile intrauterine environment now outweigh the risks of prematurity. And because our unit, as mentioned, as we heard from an earlier presentation, doesn't have continuous CTG monitoring, or generally these deliveries all have to happen by cesarean section, which we know has its own complications. So knowing that we're dealing with these high-risk pregnancies where the outcomes, especially for the early onset IUGR babies, are usually dire anyway, and then recommending cesarean deliveries for these women, hoping that they do take a live baby home. The purpose of this study was now to determine, okay, are we really managing to achieve this? Because we know that ultimately the product of a healthy baby going home with a mother is not only dependent on the fetal medicine unit, there are other players. It's a multidisciplinary team that has to take part in these babies. Because after their diagnosis and surveillance, the delivery or preparation for delivery and care of the baby are taken over by other teams, being other obstetricians, theater staff or labor ward staff, and the neonatologist. So the study was justified mainly because the other studies that have been documented and that were being quoted, since yesterday, have mainly been carried out in developed countries, well-resourced countries where resources are actually there to optimize the outcomes of the preterm babies. And then in our unit or at Salim Gabe Hospital, the survival of these babies have really, of preterm babies in general, have been shown by studies and audits to be generally poorer than what is expected. For instance, to say the survival of a baby born weighing 1,000 grams is about 10% in our unit. And this is much less than, is now documented in literature. And some contributing factors in our setup, we have to do with neonatal sepsis and lack of equipment to support the respiratory system, which would be usually not very developed at the lower gestational ages. So we wanted to really find out to say, in our setup, are we really managing to improve that outcome, to improve, as mentioned, like yesterday, Mr. Zanga mentioned that, early delivery can actually improve the morbidity and mortality by 4 to 5 times. So are we doing this? Are we managing to achieve this? Or if we're not, then which factors need to be improved on in the system so that we can be able to allow our women to benefit as they would have, been coming for the routine surveillance, which takes a lot of time, and then been admitted and taken for a cesarean section, all this in an attempt to guarantee that they take a live, healthy baby home. So the objectives, the main one was to determine the early neonatal outcomes of these growth-restricted babies were delivered before 34 weeks at Salim Gabe Hospital, indicated by the abnormal Dopplers, and as well as determine the contributing factors to the morbidity and mortality of these growth-restricted preterm babies. So the design of the study was a secondary data analysis retrospective study, which utilizing data from the fetal medicine unit in Salim Gabe Hospital, the labor ward records, the theater records, as well as the nursery neonatal unit records, to determine their outcomes. A sample size of 172 was calculated, and the starting point were the fetal medicine unit records, which were from February of 2020 to February of 2022 that were available at that time. But there was a section that was missing, as there was a challenge that I think the database had a problem at some point. So there were some missing records within that time period. And unfortunately, because of that, the sample size could not be reached. And however, the outcomes that were of interest were mortality, and then the birth weight, to say at which estimated fetal weight or birth weight do we get an increased chance of survival, so that we can better be able to counsel a woman when we're seeing her in the fetal medicine unit to say what are her chances of taking this particular baby home based on our previous experience. And then also to say which Doppler abnormalities were associated with the less chance of survival, and the Dopplers associated with longer staying within the neonatal unit, as well as the morbidities that entailed the morbidities that the fetus is experienced, as well as any maternal factors that were relevant to the fetal outcomes. I hope this is visible, but I will just quickly go through it, but it's documented in the next slide. So from that database, we managed to get 130 eligible women, of which, unfortunately, 60 of them could not be followed up due to certain records not being available or not being able to be obtained to get the actual outcome. And this left 70 being the ones where the records were available complete records were available from the maternal records where recommendation for delivery had been made up to the baby's ultimate outcome. And of those, 21 of them went on to deliver after 34 weeks, so they were no longer eligible for this particular study. And this mainly had to do with the delays we have in our system, where some of our colleagues, especially when the women are recommended for delivery and they have to be admitted in our high care, the level of urgency that's associated with this is not really regarded as urgent as other obstetric emergencies. So these they tend to be put at the bottom of the cesarean section list, basically, and can even sometimes be delayed by over a week. So yeah, some of them ended up being delivered beyond that relevant time period for that study. Then those who were delivered before 34 weeks were actually 49. And of these, 21 delivered babies who had demised already. And the live born babies were 28. And most of those who were delivered already demised were macerated, and a few, that's 8, were fresh stillbirths. And out of the 28 who were delivered alive, 3 went on, unfortunately, to demise within the first 48 hours after birth, and 25 survived beyond the first week of life. So this is basically explaining what that diagram was saying. And well, the main thing was that also the mothers of those babies who managed to have, to deliver live babies, actually had no comorbid conditions themselves. And most of and hypertensive disease of various degrees, were the comorbidity that was associated with most of the stillbirths. And the abnormalities in the ductus venosus were associated with most of the cases with the stillbirths. And in terms of the birth weight, 1,200 grams was the weight where the chance of being born alive became more than 50%. And as mentioned earlier, the delays in the emergency cesarean sections being led basically to a third of those babies being delivered stillborn and vaginally. For those babies who were admitted in the neonatal unit, it was mainly respiratory distress, which was a challenge. And unfortunately, in our unit, resources are not always available. So whether antenatal steroids sometimes are not within the system, and patients sometimes have to buy, but so some were delivered without actually receiving antenatal steroids. And then surfactant in the neonatal unit is reserved only for those babies who would be weighing more than 1,000 grams. So as they've seen that the chances of survival of those less than 1,000 grams are very low, so they consider it an unnecessary use of the precious surfactant. So as a discussion point, really noted that there were significant delays in the emergency cesarean deliveries, contributing to most of the deaths, actually, of all those who had been recommended for delivery. Their babies died whilst waiting for the cesarean delivery, rather than from the complications of prematurity in the neonatal period. And then the preterm babies of women who would have hypertensive disease in pregnancy were fared worse than other IUGR babies where the mothers did not have hypertensive diseases in pregnancy. Okay, so yeah, the ductus venosus contributed abnormalities were really the biggest predictor of an adverse outcome. So conclusion from the study, although the sample size could not be reached and statistically significant outcomes in terms of that were desired could not be obtained, were that definitely morbidity and mortality is high amongst these growth restricted babies who are delivered at Salim Gabe Hospital, indicated by abnormal Dopplers. And this is mainly related to the delays in the cesarean delivery, but also to do with the neonatal care. And then for birth weights more than 1,200 grams, the chances of survival beyond the early neonatal period becomes more than 50%. And respiratory distress at birth is associated with early neonatal death and also prolonged stay in the neonatal unit beyond the first week of life. So based on those conclusions, the recommendations were for the system to improve on the availability of theater facilities so that cesarean deliveries, cesarean sections for the abnormal indicated by the abnormal Dopplers can be performed within the time limit that they are recommended. Because in our system, there's staff to open the available theaters only for 8 hours. Then for 16 hours, which is the whole night, and there's only one theater which is supposed to be catering to the dire emergencies. And this partly has to do with staff availability and, well, other factors. But if resources can be availed so that, since this is a tertiary institution, these deliveries can be performed at any time during the day, and they're not put at the bottom of the list of the cesarean deliveries, we can save more babies who would need to be delivered within 24 hours. And then also for the care protocol for the preterm growth restricted babies to optimize their care within the neonatal unit, and the adequate equipping of the neonatal unit to be able to especially provide respiratory support for these delicate neonates. And definitely a prospective study to be able to explore more of these aspects that contribute to the outcomes, and to be able to achieve a adequate sample size would be most useful, because this is still a very relevant topic, and the results could probably be used even within the unit itself to convince our other team members who work with the women and could assist in changing their minds, as well as making the necessary resources available. Thank you.
Thank you so much, Dr. Mumvuma, and very interesting presentation, and also your presentation highlights the challenges that we still face in our region here in terms of providing high-end care to the poorly grown babies. So we've come to the time of questions to the presenters. So you are more than welcome. Those who are in the panelist platform, just raise your hand so that I can identify you. And for the participants, you can type your message, but if you feel really want to express yourself, like I highlighted, that's just a message the administrators that they can allow you to speak. So the floor is open for questions to all the presenters. Maybe the admin team can just push through the presenters so that people know who did what, since there were quite many. Prof, you may go ahead. Prof Chauke, please go ahead.
Thank you very much, Dr. Verenga and the team. Really, you gave us a lot to think about with these presentations. I just got a few things that I would like to ask. I think I will start with Dr. Mumvuma. You raise a very important issue about the survival of small babies. And I think in your setting, you're suggesting that probably a weight of 1,200 might be what you'll be looking for, which has got implication in terms of practice. I'm aware that you did raise that you didn't have adequate sample size. But my question, and I might have missed this, did you look at other predictors of outcome? And I'm looking at, did you, for example, perform a regression analysis? That might actually point to more than one issue, which probably working together to affect your data. The second thing is, given what you are seeing in terms of your study, are you going to change your practice and focus on 1,200 grammar, and bearing in mind that you did not have probably enough power to make that decision, but that suggests that there's a trend on that. And then I'm saying this in the context of limited resources. Then my other question is the team of Dr. Verenga and Dr. Chirume, if I remember very well, yes, about the issue of growth charts. What I wanted to know from you, which I would like to know, is have you looked at the outcome of these babies using this different chart? And then my last question is, Dr. Kanyimo, the issue around placental grading, atrial Doppler. What are you suggesting we should be doing with those babies? Because indeed we come across those babies where everything is normal, and the only thing that you pick up is an abnormal atrial Doppler in terms of delivery decisions. Thank you very much.
Thank you, Prof. I think Dr. Mumvuma, you can start, followed by Dr. Chirume and Sheila, in that order.
Okay, thank you, Prof. Chauke, for the questions. Yes, definitely. There must be multiple factors related to the survival of the babies, and actually, they were initially part of the points to be considered or in the study. However, upon looking at the system and what the records that were available had, then certain elements that probably do contribute could not be included in the study per se. And that's the proposal for really to repeat the study and do it in a prospective manner where data capturing and gathering and recording of everything is intentionally done, because yes, the fetal medicine unit has the electronic database, but then like in the labor ward, the theater, or in the neonatal unit, actually the data that they have, although they have an electronic database, that one is anonymized. It's mainly to just review and give information on what happens on these conditions, not necessarily on a specific baby. So they can't be linked, let's say, to the fetal medicine unit records. So yeah, I think with a prospective study, we're looking at all the more variables that can be significant. Yes, regression analysis with all multiple factors would really be significant. And then for the second question, certainly at this point, no, we cannot change to say 1,200 gram babies is where we'll offer cesarean delivery based on this study, which was not statistically significant at the with adequate numbers. And so would rather advocate for improvement within the system of various factors to enable us to ensure survival of smaller and smaller babies, and whilst preparing to do the prospective study. Thank you.
Dr. Chirume.
Thank you very much, Prof, for the question. Unfortunately, we didn't do a further study to look into the outcomes to see that if we use a different charts, is it going to affect the outcomes? But that's our next point which we wanted to do. We want to go into looking at the outcomes of those babies from different charts. Well, this first step was trying to answer the question to say that if these fetus are scanned maybe by Dr. Slaviana in Bulgaria to say they're small for gestational age, is it going to be the same if we're going to scan them this side, or even maybe a different population? Is this chart going to pick up the similar? That was the first point to say, can we sort of find a common ground to say if someone is said to be small for gestational age in Ghana, will it be the same even in Zimbabwe? So we're looking at a chart which can diagnose those. So we'll do a further study to look at the outcome to say if these charts have got different pickup rates, what is going to be the effect on the outcome? So that will be our next study, so that we can publish it maybe in the next meetings which we will be having. Thank you so much.
Sheila, do you want to respond? Sheila, would you say we need to change the protocol of FGR follow-up or no? Based on the finding. Probably Sheila is not in the meeting, but maybe all right, so maybe just comment and say, I think what Sheila study does is it reinforces what probably is already in the literature and what has been presented by Dr. Lachayo in terms of the utility of the uterinatal Dopplers, in terms of the association with FGR. But the practice that we have been doing ourselves as far as the uterinatal Doppler, placenta grade not so much. If the baby was growing well, we have not changed our approach based on the placenta grade in terms of totally changing. Of course, women who come with calcified placenta early in second trimester, we've scheduled those women for growth assessment and also blood pressure monitoring. We have done that. But those we see in third trimester, let's say from 34 weeks onwards, we have not done much in terms of changing the practice. But women with abnormal uterinatal Dopplers, we have been monitoring those women regularly. Even those with AGAs at the time of scans, we've always asked them to come for growth scans every 4 weeks. And we've also recommended them to monitor their blood pressures at home. Let me say that's the current practice we are doing. And yeah. Then there is a comment from Dr. Due. Dr. Due is an obstetrician and gynecologist specialist with a passionate interest in fetal medicine. He's a fellow in fetal medicine. Is based in one of our second biggest city in Bulawayo. So he's commenting and saying, unfortunately, we are sorry about that. Dr. Due is not feeling well. Dr. Due said he is not able to speak because of flu. His throat is hurting. We are sorry about that, and we wish you a quick recovery. But he's agreeing with Dr. Mumvuma on his post there. He's saying he agrees with Dr. Mumvuma. He's seeing the same kind of trend in Bulawayo. He's saying they used to say 1,000 grams survive, but however, over the years, they've moved up in terms of the weight cutoff. So one of the reasons why it's like this, we're going to have a neonatologist presenting. Maybe we might need to ask him a question in terms of the strategies that they are putting up in place in our country here, in terms of what they are doing to try and improve the survival of babies. Was in our region, unfortunately, the less than 1,000 is a given that they don't go home. I think the survival is less than 2%, to be honest. Then we used to say above 1,000 was 50%, but from the data from my colleague is showing actually that's not the case. And Dr. Dewey is agreeing with that. So it's an issue of strengthening the neonatal care services. Maybe we would want colleagues from other countries to comment on this particular point so that you can tell us if you are doing better than us so that we know that it can be done. Yeah. Then Dr. Chi, there's another question. Did Dr. Chulman team consider early versus late onset FGR for the different charts? I think Dr. Chulman can answer that question before we have comments from colleagues from other countries.
All right. Thank you, Dr. Dewey. We didn't go on further to look at early versus late. I think we still have the data. We can further classify and see whether for the early versus the late, whether the charts can perform differently. Because what we were doing, we were looking at, because imagine if you get a weight, let's say maybe 2,000, after plotting the biometries in the machine, then it comes up to those charts saying this is small for gestational age. You'll be basing on what has been installed in that machine, which was the hard lock. But other charts, they are still there, which means that even if you are to choose a WHO, it can give a different result to say maybe it might be appropriate if you are using the WHO, which means that we were trying, in this study, we're just trying to look at those who are small for gestational age to say amongst the charts which we have, which one can have a pickup rate, which is almost similar to the standard, which we can adopt. So we didn't further look into the early or versus the late. I think, but we can do it because we still have the data and we can publish in the next meetings.
Thank you so much. I don't know if there are still any questions from the panelists, but I think if colleagues from other countries would comment on the issue of survival, I think that would be really useful in this meeting. From Kenya, what is your survival cutoff? How far are you going with the less than 1,000 grams? Do you have anyone from Kenya? What about, certainly we have somebody from Kenya. Maybe they are still discussing about it. Then what about Nigeria? Nigeria, Tanzania? Any comments on the survival? Do you have this kind of data? South Africa? Any idea of this data to say how many of you less than 1,000 do actually go home in your neonatal care units? I didn't get any response, so I want to assume that probably people may not have this data right. Let's see, I think there is a hand. Let's see. Prof, do you want to come in on that issue?
Yes, Dr. Verenga. I don't have the actual data, but what I know from where I work, a baby that weighs more than 800 and above has got more than 50 chance of survival. And I think the issue is exactly what Dr. Mumvuma has presented. It's really an issue of resources. So in cases where you got resources, your outcome are much better. And if you can allow me, I just want to comment again on this, that if we look at outcomes, it speaks a lot about the ethical principle of restitution of justice. And I really would like to challenge the Zimbabwean team to really look at, you know, what you're providing. If your outcome is so bad with babies that are less than 1,200 grams, are you not depriving babies that are more than 1,200 grams chances of survival by inverting resources on that? And I'm saying this because one of the decisions that our team has to take here to say that, well, if we take 750, which we know we used to take all those babies to neonatal ICU, are we really doing them any favor in an area where you've got so much scarce of resources? So I really think that the team need to come together and really think very thoroughly about this particular issue, in the basis that you don't have resources. And I mean, I've been at Salmugabe, and I must congratulate the team for the work that is being done there. But you might really need to really think very thoroughly about these babies that are less than a kilogram, and whether you should really still be providing neonatal ICU, even with the limited data that we have. Thank you.
Thank you so much, Prof. I think that's a very valid point. Well, I think we hope that we'll be able to re-raise this discussion when the neonatal team presents, so that they can answer some of these questions and also bring the realities on the ground to us. So we will ask the neonatologist when he presents this kind of a question so that he can help us. In Kenya, Dr. Wanyonyi is telling us that they do not have national data, but it varies depending on the hospital that the delivery takes place. Where his practice is more like a private hospital, their survival is around 50%. Below 800 is much lower. Yeah, so I think the private sectors really, they all tend to do better. Even in our setup, the analysis of our private sector data is pretty much impressive for the babies who are 1,000. For babies who are 1,000, the survival is around 80% when you analyze the private sector data. But this is not the case. This is not the case with the public sector data, where 80% of the women actually deliver. So yeah, so probably for the next scientific forums, we may be interested in this data to just see how we are doing, because the role of fetal medicine is to try and make the high-risk pregnancy women take their babies home, and these babies should have an equal chance with another baby. That means they should be delivered at the best health status that we can deliver them, and give them probably an equal chance in life. So we need this kind of data, and we probably may need to rope in more and more for neonatology colleagues in different countries in these meetings, so that they can also share their input with us, and we can all agree on certain issues. Do you have any other questions? I wanted to ask Dr. Samira, in terms of what to do with women we have FGR. When we were saying we should try and do cardiovascular assessment on these women, how far should we assess them? Of late, we've been seeing a trend of these women. We have FGR. Otherwise, everything else is normal except that the baby is small. You check their blood pressure, it is normal. How far should you go with the assessment? Should you go on and do a fetal echo on these women? Because we normally just tell them to monitor their blood pressures at home. I think that's the basic. We ask of all the women with fetal growth restricted babies without hypertensive disease or pregnancy. So how far should we go, Dr. Samira?
I mean, it's always it's obviously always a question of resources that you have. I think it's probably not feasible, even for us. It will not be feasible for all the mothers who have growth restricted babies to actually send them for an echo. I mean, if you can do that, it will be very good. But I think the most important thing is that you educate these women, because if they're preeclamptic, they have noticed that there was something going on with their bodies as well. They have seen their blood pressure rising. They have seen edema. They have probably felt not healthy. But if they had just had a small baby, and for themselves they felt fine, they might not be aware that there is something in their bodies that is also going to cause them problems in the future life. So I think the most important thing that you can do is to educate these women, not to tell them, okay, go home and have your blood pressures checked, because you know they will be mothers, they have a small baby at home, and the least thing they will care about is their own health, because they will be focused around their kids, they'll be focused around their work at home to keep everything going, and they will not check their blood pressures if they don't feel anything, if they feel healthy. So I think you have to educate them that even though they don't experience any acute symptoms, they are at an increased risk, and they should see maybe the general practitioner regularly, just to have a check on blood pressure, because if you recognize it early, you can treat it early and lower the cardiovascular risk. You can advise them to maybe if they're obese, for try to exercise, try to keep a healthy diet, try to like all those lifestyle modifications that you can do, that we know will change the cardiovascular risk. We have to be aware in order to grab signs of illness early, to reduce the risk. I think this is the most crucial thing. Obviously, okay, if you can do more investigations, we are starting now on non-invasive assessment of cardiovascular status with non-invasive devices, but we have just started and we try to follow up women, but it's just in the study now, so it's not our daily business. We are actually just doing what I've just told you. We are trying to educate them to take care of their health and try to treat symptoms of cardiovascular disease early, lifestyle modifications, in order to keep the risk as low as we can.
Thank you so much, Samira, for that answer there. The follow-up question again is on women who have preeclampsia. There are certain women we come across who have had probably preeclampsia in their past 2 pregnancies. Very bad preeclampsia, severe disease with very poor outcomes. The question is, at what point should we do the cardiovascular assessment, and how far should it go again for this kind of women who are very high risk for preeclampsia? Should we order an echo for these women at any point in their pregnancy care, or an echo is not necessary, just blood pressure monitoring?
So I think the biggest thing that you can do for women who have had once or twice preeclampsia is to give them aspirin from early on, because we know that aspirin is also a drug that modifies cardiovascular risk. So apart from the study that we all know from the ASPI trial, so aspirin will be the most important thing. And I mean, if you know the cardiac function of these women, it won't change anything, because we already know that if she had suffered from preeclampsia twice, that your cardiovascular system is not coping well with pregnancy. Pregnancy is like a stress test for the maternal heart. And if the heart hasn't passed the stress test twice, it won't pass the 3rd time. And we know from clinical practice and from the data that preeclampsia in pregnancy is usually getting worse, because the heart is strained more and more, and the onset of preeclampsia is usually earlier every time the woman gets early onset preeclampsia, because the heart is not coping well. We also know that if there is a bigger interpregnancy interval, a longer interval, that preeclampsia can be less severe, because the heart has time to recover. We used to think that in women who changed partners, that the preeclampsia risk went down because of immunological factors, but it seems more that it's the interpregnancy interval that is actually reducing the risk of preeclampsia. So I think if pregnancies, I have no data to say this, but it's just, if the heart has some time to recover, it's probably better to have some space between pregnancies. But once a woman has classified as having an underlying cardiac dysfunction, you can do an echo to actually verify it, but it won't change the care that you can deliver. You have to take care of these women. You have to give them aspirin. You have to monitor their blood pressures. But once she goes into severe preeclampsia, it's just clinical management.
Thank you so much. Samira, I think that should suffice. I think I have another question for Dr. Slaviana. The FGR, normal Dopplers, baby small, NIPT normal, suspecting placenta-confined mosaicism or trisomy. Obviously, amniocentesis is going to miss these cases, like you said. So, should we be taking placenta tissue for these babies, like QFPCR? You say it will pick up the placenta-confined disorders, or you suggest we should investigate further? Because we have these women quite often in the private sector, baby small, NIPT done, low risk. Sometimes they may end up saying, go ahead and do amniocentesis. The result come back as normal from amniocentesis. In our region, it's too very complicated to do the whole exome sequencing and the whole genome sequencing study. And also the chromosome microarray, I think it's almost 1.5 times the price of conventional karyotype. So this is where we are, but I just wanted to know if what you think, to say, should we just go ahead and do CVS then for these women?
Thank you, Claudius, for the question. So the scenario that I am most afraid of is if I have a known due date, so I'm certain of the dates of the pregnant woman, I have small baby, normal fluid, and normal Dopplers, especially if the baby is below the 3rd centile. Then, and if the growth velocity is dropping, then I'm most worried, just because of the risk of genetic syndromes. They can be anything. And with the QFPCR, you can exclude the most common chromosomal abnormalities, but this is not enough. And there is enough data to support that some of the conditions, especially microdeletions, microduplications, they cannot be picked up with just this test. And patients should be aware that if you exclude placental insufficiency, if you exclude infection as a reason, there is still a chance, a high risk chance for conditions, genetic conditions, that they cannot be picked up with the conventional karyotype. So these are the cases that I'm most worried. I don't know if you have any data in your settings.
We do have this data. We'll probably share with you guys at some point. But we are beginning to see a lot of women, especially in the last 6 months or so, so that we begin to think that could this be the residual effect of COVID on women? Because we are seeing a lot of babies now whose mothers are otherwise okay, no blood pressure, but the placenta just failed, and we run all these tests and they come back normal. Yeah, and some babies have already been born, actually, and we've been following up these babies, and the mothers have been telling us that my baby is normal, but the placenta failed at some point in pregnancy and the baby didn't grow. Some grow probably to just 2 kilos at birth, at term actual, around 37 weeks. So we are seeing more and more of these cases. I think right now, I think I'm following up 3 to 4 women like that, who otherwise have everything normal, but the placenta is not giving the baby what it needs. So yeah, so this was my question to say, what kind of, should we do CVS? Because placenta confined mosaicism or trisomies seems like it's very difficult to pick with doing the karyotype, and even when you run the NIPT screening, it's not picking up anything.
If it is confined placental mosaics, NIPT can be false positive for some of the conditions, for example, trisomy 13 and 18. But if you do an amniocentesis, it will be normal. So the condition is only in the placenta.
Right.
It can give us fetal growth restriction.
Have you done any postnatal placenta studies on some of these babies? Because we have been collecting placentas and sending them for histology. Unfortunately, the reports are not very different. They are showing the usual stuff, things like syncytial nodes, the sparsely populated the villi. They are also showing us the fibrin deposition, the usual stuff that's associated with common placenta insufficiency.
There was a study by Neil Sebire about the placental histology, and in his study they have blinded the pathoanatomist, so he didn't know if it was a preeclamptic placenta or normal placenta, so all the results were more or less the same. So they didn't give them enough information. With genetic testing of the placenta, it will give us more information. However, nobody is sending placentas for genetic testing, only in studies. And there was one very nice presentation by Tessa Humphrey about confined placental mosaics. And based on her study, she found that more than 20% in the cases of fetal growth restriction, there were confined placental mosaics, which is chromosome specific, because not all chromosomes can give us small babies. For example, Down syndrome is very rarely small. They may have abnormal Dopplers, but they are not small. However, trisomy 13, 18, and 16, they are small.
All right. Thank you. Thank you so much. I think that is very useful. And we should always think of this placenta confined mosaicism in our line of work, because we have quite a number of these babies. Let me read through the comments, then Grenda Mazara will speak. Is it correct? This is Dr. Ascolia Wanyonyi from Kenya. Is it correct to label a fetus as FGR and first trimester with CRIL? Shouldn't that be the correct gestational age? I would readjust the age based on the CRIL and use that as the reference. I think this is clear, but we should always remember that sometimes we see these fetus who have disproportionate growth in first trimester, such as in cases of triploidy. So triploidy, the growth can be questioned even in first trimester in cases of triploidy. When you take your CRIL, you can clearly see that the head is big, the rest of the body is very tiny. So that's when the suspicion will begin. We do not have data okay, I think this I've read it, from Feben Obake, Dr. Obake from Nigeria. Greetings everyone. From Nigeria, I don't have the data, but in the teaching hospital where I work, birth rate of 800 to 1,000 survival is about 40%. I think it's impressive. Thank you. Then Dr. Abdel Azim This is okay. This is Prof. Chauke just commenting on what Samira said. Thanks, Dr. Abdel Azim. This is something we have to think about. Your presentation makes sense and has given us further insight on the pathogenesis of FGR. Then Dr. Marere is one of our colleagues here, specialist obstetrician gynecologist, and also a minimum access surgery specialist. So she's commenting here, say, thank you for the for the insightful talks. I've noted a surge in late onset FGR babies who were growing well. Then around 34-35 weeks, growth slows down significantly with normal Dopplers, no preeclampsia, and no other maternal or fetal problems. When should we deliver, or by what mode? I think Dr. Marere, Dr. Marere is voiced what I just voiced here, that we are seeing more and more of these cases. In terms of the delivery plan, I don't think, I think they will follow the same protocol which was discussed by Dr. Lachwayo, whereby they will be monitored to around 30. For us, normal and abnormal Dopplers, normally our delivery, if the Dopplers are normal, we've been doing it between 30 to 39 weeks, is recommended by most international guidelines. But if the Dopplers get range or slight increase in the PI, we've been delivering them around 37 weeks. But if my colleagues here have other ways of seeing things, they will comment on it. They are not currently when to deliver late onset. Okay, it has been commented today on Dr. Samira. However, a big multinational Eurocentric trial is currently underway to assess the best timing, early and 2 years outcome. So that's what Dr. Samira is commenting on there. Then Dr. Helen Marina from Tanzania, the take-home babies is around 60%. Thank you so much. That's impressive. It would be great to indicate with the private or public sector, because there are two heterogeneous settings in our region. So the study, okay, so that's the truffle too. So that's the public sector, where Dr. Marina said 60%, which is the public hospital. Very impressive, really. I think we need to learn from our colleagues who are getting these impressive figures on the less than 1,000 babies. Great. I think I've exhausted all the comments, and let me see. Maybe I could have jumped someone. Should we be doing Dopplers in AGA fetus? How do we act when we say CPR is abnormal, but fetus is AGA 36 weeks and beyond? Any takers from the panelists? Dr. Wanyonyi from Kenya is asking us whether we should be doing Dopplers in AGA fetuses. And what will we do if the CPR is abnormal? Do you have any takers from the floor? Dr. Slaviera, do you want to comment on Dr. Wanyonyi's question, or to, yeah, please go ahead.
Yes. So always you should take in mind not only the Dopplers, but the CTG, the fetal movements, the maternal condition, when you want to decide if you want to deliver the baby or not. So if you have AGA and if you are not certain about the CPR, for example, only the middle cerebral artery you find abnormal, bring the patient again the next day if all is normal. So the mother doesn't have hypertension, doesn't have diabetes, for example, the baby is well grown, it follows the same growth velocity, the CTG is normal. You should always question if this measurement is correct. If, for example, it's abnormal, especially in hypertensive patient, then you should follow the local protocol for delivery, either induction or cesarean section. It depends on the conditions.
Thank you so much. And yeah, maybe to add, I think there is a study done by Professor Ranja Koleka where they were looking at the prediction of the CPR and normally grown babies, and they didn't see a poor outcome associated with that if the baby is normally grown. So besides checking for the false positive, because there are lots of false positives for sure, like what my colleague has highlighted. So always be aware that you need to double check things. But otherwise, normally grown, just the CPR, you've ruled out all the risk factors. It might not be because of to deliver, but we monitor the baby and other